All right, everyone. We're back. Got a lot of content this week. We're back to talk about aneurysms. I'd like to give you a little bit of a break. So I break the lectures down, um, how they're just a little bit more digestible than you just to sit there and read or watch and watch and watch and watch. So aneurysms. Okay. So types of aneurysms. An aneurysm is a localized sac or dilation formed at a weak point in the wall of the artery. We classify these by shape and form. So a saccular aneurysm projects from one side of the vessel. A fusiform aneurysm is an entire arterial segment that's dilated. A mycotic aneurysm is very small aneurysms due to localized infection. So here we have a diagram. So A is that normal artery where we have the three layers and it's working just fine. B is a false aneurysm. So it's got a pulsating hematoma, clot, or connective tissue, but it's outside the arterial wall. Okay. So it's not connected to the actual inside of the arterial. And then C is that true aneurysm. So you see that pouching there. It may involve one, two, or all three layers of the artery. We have a fusiform aneurysm in D. D is a symmetric spindle-shaped expansion of the entire circumference of the vessel. E is that saccular aneurysm where you see that bulbous protrusion on one side of the arterial wall. And then F is that dissecting aneurysm. So it's a hematoma that splits the layers of the arterial wall. Causes of an abdominal aortic aneurysm is it's often attributed to atherosclerotic changes in the aorta. It's potentially serious and rupture can lead to hemorrhage and death. So not great. Etiologic classification of arterial aneurysms. So we have that anastomotic and graft aneurysms, which are caused by infection of the anterior wall. The arterial wall fails, and then we could have a suture or graft failure as well. We can have congenital associated with connective tissue disorders. So that could be like your Marfan syndrome, your Ehlers-Danlos syndrome, and other diseases, focal medial agenesis, and tuberous sclerosis. Pay attention to Marfan syndrome and Ehlers-Danlos syndrome. That would be something that you want to highlight. That is definitely asked when we talk about aneurysms, whether again on the NCLEX or ATI. Infectious is resulting from bacterial, fungal, or spirochetal infections. Inflammatory is linked to the arteritis. So the Takayasu disease, giant cell arteritis. And then we have that periarterial inflammation. So something like pancreatitis can cause these things. Mechanical is related to that post-stenotic conditions and arteriovenous fistulas. And then we have pregnancy-related degenerative aneurysms. So pay attention to this as well when you're talking about OB. It's non-specific inflammatory variants and then traumatic, resulting from penetrating or blunt arterial injuries. Let's talk about thoracic aortic aneurysms now. The prevalence is approximately 70% of thoracic aortic aneurysms are caused by arterial sclerosis. So that is something that can be fixed, right? Good diet, good exercise. Okay. The demographics for people that are experiencing thoracic aortic aneurysms are it's most common in men aged 50 to 70 years old. It affects about 10 per 100,000 older adults. Complications here are high morbidity and mortality. Endovascular aortic repair has improved outcomes. with a mortality as low as 4.8 at high volume centers. Clinical manifestations are symptoms, or they vary based on the aneurysm dilation rate and effect on surrounding structures. Patient could be asymptomatic. Uh, if they have pain, it's going to be that constant boring pain. And it's going to happen when they're supine. They might have dyspnea due to that pressure on the trachea, main bronchus, or lung. They're going to have a cough that's paroxysmal. I can't speak tonight. It's kind of late. Often with a brassy quality. We're going to have some hoarseness or stridor due to that pressure on the laryngeal nerve. Aphonia, which is a complete loss of voice from the nerve pressure. And dysphagia, difficulty swallowing due to esophageal impingement. Our physical exam is going to show that dilated superficial veins in the chest, neck, or arms, edematous, I should stop. Edematous areas on chest wall and cyanosis may be present. We could have unequal pupils, which may indicate pressure on the cervical sympathetic chain. And then for diagnostics, we're going to get chest x-ray, CTA, magnetic resonance angiography, MRA, and then a transesophageal echocardiography, TE. We're going to really focus on that CTA, that CT angio, because it's readily available and we can get it done really quickly and it's pretty accurate. So we're going to focus on that. So we're going to focus, our treatment is going to be based on the size and symptoms and presence of dissection or branch vessel involvement. We're going to make sure that we have blood control, blood pressure control, and risk factor correction. We're going to give beta blockers. That's our main treatment. So your olols, your atenolol, metoprolol, carvedilol. We can give angiotensin receptor blockers, those ARBs. They help lessen that aortic dilation. That's going to be your losartan and your valsartan. And then we can do preoperative blood pressure control where we want to target that systolic pressure to 90 to 120 with a MAP of 65 to 75. And then for emergency management, we're going to give that nitroprusside. It's used for rapid blood pressure reduction via continuous IV drip. So if we go surgical management, our goals are to repair the aneurysm and restore vascular continuity using a vascular graft. We're going to have intensive postoperative monitoring required in critical care units. This patient is not going to go to your average med-surg unit. So if we have endovascular repair, the techniques for that are endovascular grafts are placed percutaneously. The advantages to this procedure are shorter recovery time and fewer complications compared to traditional surgery. And for graft materials, we're going to use PTFE reinforced with nitinol or titanium stents. The complications are risk of spinal cord ischemia, 2 to 15%. So we see the complication, we want to prevent it, right? So we're gonna put lumbar spinal drains to improve spinal perfusion, maintain cerebrospinal fluid pressure at less than or equal to 10 millimeters of mercury, and that MAP is going to be greater than 90 for 36 to 48 hours post-op. Now let's move to abdominal aortic aneurysm, AAA. The most common cause again here is the atherosclerosis. The prevalence is for this AAA is that it affects men 2 to 6 times more than women, 2 to 3 times more common in white men than black men, and most prevalent in patients greater than 65 years old. Pathophysiology here is our location is typically infrarenal. Our risk factors are genetic predisposition, nicotine use, and hypertension. Our complications are rupture leading to death. Our symptoms here Patients are gonna 40% of patients are gonna be symptomatic. We're gonna have that abdominal mass or throbbing, possible emboli leading to cyanosis and modeling of toes. If this ruptures, know these signs. If this ruptures, we're gonna have that severe back and abdominal pain, that falling blood pressure, decreasing hematocrit, and possible heart failure if ruptures into the vena cava. So here we're gonna assess for that pulsatile mass in the abdomen. We're going to do a duplex ultrasonography and a CTA. And we are going to monitor this patient every 6 months to make sure it's not getting worse. There are some gerontologic considerations. When we talk about gerontologic considerations, we're going to talk about the age group of 60 to 90 years old. Their rupture risk is greater with hypertension aneurysm greater than 6 centimeters. And we want to we want to not repair this until it's 5.5 centimeters because surgery is a risk. Our medical management for this is we want to do blood pressure control with antihypertensives, so like diuretics, beta blockers, and then we might do endovascular or surgical repair. Endovascular repair is preferred for intrarenal aneurysms, and open surgical repair is for large or enlarging aneurysms. Nursing management here is for pre-procedure, we want to assess organ systems for impairment. Post endovascular repair, patient's going to be in the supine position for 6 hours. We're going to monitor those vital signs and pulses. We want to assess for bleeding, hematoma, signs of embolization. Post implantation syndrome is the symptoms for post-implantation syndrome are fever, leukocytosis, and we're going to give analgesics and anti-inflammatory agents. We want to make sure that these patients stay hydrated, so we want to encourage fluids to maintain blood flow and kidney function. We want to gradually increase post-procedure mobility. We want to discontinue that IV once we can do oral intake. And then post-op monitoring, we want to check pulmonary, cardiovascular, renal, and neural status. Complications can include arterial occlusion, hemorrhage, infection, ischemic bowel, kidney injury, and erectile dysfunction. And other aneurysms that we should note are always going to be caused by arterial sclerosis, and the affected vessels to watch for are that subclavian, renal, femoral, and popliteal. That's going to be your most frequent. Popliteal artery aneurysms, the incidence is 50 to 60% bilateral, 0.1% to 3% of adults. It's often linked with abdominal aortic aneurysms. The clinical manifestations are going to be that pulsating mass, disturbed peripheral circulation, pain, and swelling. We're going to diagnose these with a duplex ultrasonography, a CTA, and arteriography. Complications here are distal embolization, not rupture. And the treatment is going to be surgical repair with grafts or endovascular repair with a stent or wall graft. That's it. That is it for our aneurysms. So I will see you at the next lecture.